although the notice was disseminated within 2 weeks, but still a lot of people have shown response that itself is motivating. And I'd like to thank all the technicians who are actually doing India, making India proud, that they are the backbone of banking. Unless they are working, it's like a soldier who is in the field. Unless they are working, I don't think cornea surgeon or eye banking will go forward. But still, we have lot of things to do. We have to improve the quality of the training, and at the same time, more eye bank need to be developed. And this the one goal of this is that people will remain up to date about the what is happening around the world. So this will be a regular thing. But the first one we start with a good number. And before Neeti start, I'd like to thank Neeti to ready. She's a passionate teacher and eye banker. She's ready to take the first class, which is ocular anatomy. I'd like to thank EBAI team and Rakhi and Ganesh for planning this meeting, and all the speakers who are talking in future webinar. And last but not least, IPCA to agree to support this webinar. So we'll encourage you to as many as questions as possible, but not, please keep the mic mute, and we'll take the question at the end. You can write in the chat box. Thank you and welcome again.
Thank you, ma'am. Thank you so much, ma'am. I request all the participants to mute themselves, please. Before we start the webinar, I would like to introduce our guest speaker today, Dr. Neeti Gupta. Dr. Neeti Gupta currently works at the Department of Ophthalmology, AIIMS Rishikesh. She is working as an additional professor and a medical director at the AIIMS Rishikesh Eye Bank. She is a cornea specialist and has around 13 plus years of experience in teaching. Her special interest is in corneal transplant and eye banking and ocular surface. Her most recent publication is correlation of mebioscale symptom score and sign score for primary meibomian gland dysfunction in Indian eyes. Welcome, Dr. Neeti, and thank you so much for agreeing to start with the first webinar for us. Thank you.
Thank you, Rakhi. And I would thank the EBI, the whole team, Dr. Sujata especially, and Rakhi for giving me this opportunity. So should I share my screen?
Yes, Dr. Neeti, you can share your screen now.
So thank you once again for giving me this opportunity. And I think as Sujata ma'am just said, that I think this webinar is all like most of the technicians and counselors are there, and you are the workforce behind the eye donation program. So we will start right away. So first of all, why should our counselors and technicians should know about the anatomy of the eyeball? Because first thing is that when you are counseling the family, there are a lot of questions from the family, donor family members itself, that वो बहुत बार क्वेश्चन करते हैं कि आप क्या मतलब कौन सा पार्ट आई का निकालेंगे. उनको बहुत मिसकंसेप्शन होता है कि पूरा का पूरा आई लगाया जाता है. तो सबसे पहले जब हम काउंसलर्स को पता होगा, when we as counselors we know that what part we are using for corneal transplant, it will be easier for you to counsel the family. There's a very small incident I'll tell you, that in our eye bank, when it was very new, one of our counselors, they counseled the family कि हम पूरा eyeball नहीं लेते हैं, हम सिर्फ corneoscleral button लेते हैं. But because they were initially like in few cases they did eyeball retrieval because contraindicated cases थे. So वहाँ पे families में बहुत लड़ाई हुई. So we should be very clear what we are doing, and we should explain thoroughly to the family members कि आई की anatomy क्या होती है, क्या part होता है, क्या हम use करेंगे. Second thing is for retrieval of the tissues or eyeball. So in some eye bank we are doing eyeball retrieval, कहीं पे हम लोग corneoscleral tissue retrieval कर रहे हैं. So we should know कि कौन से structures हमें काटते हैं eyeball को retrieve करने के लिए, और कौन से structures हमें काटते हैं for corneoscleral retrieval, and what are the structures we should not damage during this retrieval process. And the third important thing is the for proficiency for pre-cut tissues. तो आजकल आई बैंक्स में जैसे एलवी प्रसाद है, आई थिंक श्रॉफ, सब जगह पे like most of the good eye banks, they are doing tissue retrieval and technicians are actually doing this pre-cut tissue. आजकल सारे corneal surgeons, most of them are going from full thickness transplant to DSEC और DAL. तो इसके लिए pre-cut tissue कैसे काटते हैं, तो हमें कॉर्निया का एनाटॉमी बहुत अच्छे से पता होना चाहिए. So we see these beautiful eyes and like we are going for this noble cause for corneal blindness. तो हम anatomy जो है इसको 3 parts में study करेंगे. सबसे पहले एक है eyeball, तब समझेंगे एक eyeball क्या है, ocular adnexa क्या है और extraocular muscles. इसको एक मोटा मोटा 3 parts में we will understand. So if you see the face, I think figure 1, everybody is familiar. This is the normal face. And अगर हम उसका आगे से skin, and you can see this is the eye. Can you see my pointer?
Yes, ma'am.
Okay. So this is the eye. और इसके ऊपर ये होता है eyelids and eyebrows. And this gives a beautiful picture to the face also. So जब हम इसका सिर्फ skin और नीचे का fat अगर हटा देते हैं, तो जैसे figure 2 है, इसमें हमें दिखेगा muscles. So these are the muscles around the eyelids. तो अब मैं छोटा बस आपको एक अंदाजे के लिए फोटोग्राफ्स दिखा रही हूँ. अगर हम इन मसल्स को भी हटा देंगे, सो वी सी दी आईबॉल एंड उसके अराउंड जो उनका ब्लड सप्लाई या वैस्कुलर स्ट्रक्चर होता है. एंड इफ यू सी दिस, अगर हमने आई मसल सब कुछ हटा दिया, ये बोन्स है, तो दिस इज दी बोनी ऑर्बिट. तो हमारा जो आईबॉल है इस ऑर्बिट के अंदर होता है. सो दीज आर मेड बाय दी बोन्स. एंड हम कहते हैं कि आईबॉल एक बोनी हाउस के अंदर प्रोटेक्टेड रहता है. तो ये जो बोन्स है इनका फंक्शन होता है आईबॉल का प्रोटेक्शन. एंड ये जो अब व्हेन वी रिमूव ऑल द ब्लड वेसल्स आल्सो, तो यू सी दिस इज द आईबॉल. जो व्हाइट पार्ट दिख रहा है ये आईबॉल है, उसके साथ में सारे मसल्स अटैच्ड है. ये मसल्स हमारी आईबॉल को मूव करने में हेल्प करते हैं. Now we will see
Neeti, just a request, if you can also use the English simultaneously.
Okay.
Request coming in. Yeah, thank you.
Yeah. Right. So now this is the side view of the eyeball. Now we have removed the bones, muscles, everything. Now only the extraocular muscles are there. This is the eyeball. This is the lateral section of the eyeball. So side का lateral bone हटा दिया. यहाँ पे you will see those muscles. And ये muscles, they are binded by a cone in the like behind the eyeball, and like the optic nerve is attached to the eyeball from behind. I'll discuss each and every structure in detail. I'm just showing you the anatomy of the eyeball here. So this again, this picture is the lateral view of the eyeball, and ये हमारा middle side पे nasolacrimal duct है, from where the tears will drain into the nose. And I'll just show you a visual of the eye inside the orbit without the bones. So you can just visualize the anatomy, then we'll study about the eye. So this is the eyeball with the muscles attached to the eyeball. Now, this is the side view without the lateral bones of the orbit. In fact, all the bones of the orbit have been removed from this model. And you can see how the muscles are attached, and then how they come together at one point, which is known as the zonular stem. And the optic nerve. So all these are the tissues which we need to cut when we need to remove the whole eyeball. So the lids are separated and eyelashes are also separated. Conjunctiva is cut 360 around the cornea. Tenons is cut. Then we come to the extraocular muscles. We have to cut all the 6 extraocular muscles. And then finally we cut the optic nerve to remove the whole eyeball. Right? And then if we see the eyeball as such, so eyeball has got 3 coats. So the outermost coat is the fibrous layer, outer fibrous layer, which is sclera and the cornea. Cornea is the transparent part of this fibrous layer, and the sclera is the white opaque part of this transparent layer. Then the middle layer is the vascular layer, which supplies the blood. So in front, this is the iris. Then here comes the ciliary body. And then the black line, which you can see, is the choroid. Right? So this is the vascular layer of the eyeball. Then comes the innermost layer, which is the retina. So retina is the sensory layer of the eye, and whatever image is formed on this retina is transmitted by the optic nerve to the brain. Okay, now in front of this cornea and in between the cornea and the iris, you have a chamber which is known as anterior chamber. Now this chamber has got a fluid inside it which is known as aqueous humor. Then comes the pupil. So pupil is the aperture between, or the iris is deficient in the center. So this is known as the pupil. I'll tell you the role, like when we'll just memorize and learn the structures of the eye just now. Then behind the pupil is the lens, which is there in the eye, and cornea and lens, they help in focusing the light to the retina so that a clear image can be formed, right? Then comes the posterior chamber. So between the lens and the retina, there's again a clear space which is known as the posterior chamber. And inside this chamber, it is a jelly-like structure which is known as vitreous. I hope it is clear. So now one by one, we'll talk about each of the structures. So first is lid and eyelashes. So whenever we are doing an eye retrieval, first thing we come across is the eyelids and the eyelashes. So what is the function of this eyelid? These eyelids have got muscles inside it, the muscles, and they cause the lids to close and open. Now, this is a very important function of the eyelids because it helps in protection of the eyeball. So you must have seen somebody, if they come like throw something forcefully or just point a finger forcefully in front of your eye, your lid blinks and closes the eye. So this is the protective function of the eyelids. Or eyelashes, they also help like in ways of by protecting, it gives like beautifies the eye first of all. Second thing is whatever debris or dust or anything which is coming close to the eye, this gets trapped in these eyelashes. So the very important point when we are doing an corneoscleral or eyeball retrieval is we need to clean these lids and lashes very nicely because they can be source of infection. And second thing is that when we are doing a corneoscleral retrieval, many times what happens, there are eyelashes which cut and come inside the corneasol or the MK media with the cornea. So this should also not happen because this will lead to infection of the cornea. So this is all about lashes and eyelids. Then the next layer which we come across when we are doing the retrieval is the conjunctiva, and below the conjunctiva is the Tenon's capsule. So now what, if you see when you just pull your lower eyelid, you will see this pink layer, and over here you will see again some vessels going over the coming towards the cornea. So this part is known as the conjunctiva. So conjunctiva starts from the back side of the lid, upper lid, then usko pura coat karte hue it goes behind the upper lid, and then it comes in the fornix. So this line where what you see is the fornix. So it is there in both the upper and the lower lid. So from the fornix it turns anteriorly and then it comes and get attached to the limbus. So the line between the cornea and the sclera, the junction is known as the limbus. So this conjunctiva then comes and get attached to this limbus. So the second structure which we need to remove when we are doing a corneoscleral retrieval or eyeball retrieval both, then that is that we need to cut this conjunctiva 360 degree. That means throughout the cornea, around the cornea, you will cut it 360 degree and you will separate that. And this cornea is a mucus layer, like we have layer in our inner part of the nose and in the lips and in the throat. So it's like that mucus membrane which secretes lubricating substances and part of tears, which keeps the cornea clean and the surface, ocular surface clean. This is the basic function of the conjunctiva. Now, then coming to the next layer, which is the cornea. So you can see this is the model of the eye and this is the natural eye which we see. So the blue part, the part which is colored in blue is the cornea. Now this cornea is like when we see the eyeball, the outer layer of the eyeball, suppose this is the whole circle we divide into 6. So the first 1/6 part of the cornea of the layer is the cornea, which is transparent, and the rest 5/6 part of the globe, which is the sclera, it is white. Right? So the basic function of this cornea is focusing the light which is coming from outside into the eye and then helps in focusing it towards the retina. And this is the basic structure we are all working for. This is what we are using for corneal transplant. So ये जो cornea transparent cornea है, इसको हम लोग transplant के लिए use करते हैं. बाकी और कोई structure corneal transplant में नहीं use किया जाता है. ना तो पूरी eyeball use करते हैं, ना like लोगों को बहुत सारे misconceptions होते हैं, तो we don't. The color of
Please mute yourself.
So the color of the cornea is transparent. यहाँ पे जब हम cornea को front view से देखते हैं तो it appears like colored. So that is the color from the iris and not from the cornea, right? So the shiny part in front of this iris is the cornea. Now, I'll give some emphasis on the layers of the cornea also, because this is again very important if we are doing a if we cut the layer of a cornea, so vertically what we will see, cornea is divided into 6 layers. So सबसे ऊपर वाला जो layer होता है, this is the epithelium. Now this helps in again the protection of the eye, and when we are doing the retrieval, sometimes we damage this epithelium. So that is also we need to take care. ये every 14 days में ये renew होती है and new epithelium comes. Right? उसके नीचे एक membrane होता है. This is the Bowman's membrane. Below the Bowman's membrane is the stroma. So the stroma is made up of collagen fibers, and the arrangement of these fibers specifically make this cornea clear. So what happens is, जो इनका जो cornea के collagen होता है, अगर the way it is arranged, if suppose there is a some problem in the some other layer जिसमें यहाँ अंदर water आ जाता है, so this will lead to corneal increase in the corneal thickness, and this will lead to corneal edema. ठीक है, cornea opaque हो जाएगा. Similarly, if suppose something injures the cornea, Bowman's membrane cut हो गया, and it goes in the stroma, so it will lead to corneal opacity. So the corneal blindness is because of two things. One is corneal opacity, cornea पूरा white हो गया. दूसरा चीज क्या होता है, the problem in the last layer of the cornea, which helps, we'll discuss it later. So उसमें अगर वो damage हो जाता है, तो then the cornea will not, like the fluid will come in the corneal stroma and it will cause opacity. So these are the causes of corneal blindness. Now the fourth layer is the Duas layer, right, which is just the posterior part of the stroma. After that comes the Descemet's membrane. This is another kind of a basement membrane over which these endothelial cells are attached. Now, these endothelial cells are very, very important. I think you all do specular microscopy in your eye bank, and the cells, the hexagonal cells which we see, and the count which we write, endo count, these are these endothelial cells. So the most important function of this endothelial cells is to pump water out from the cornea. So what happens if suppose there is excess fluid in the stroma, so these endothelial cells will pump this water out and will make the cornea relatively dehydrated. So the layers, the corneal transparency is maintained. So any disease or any injury or any surgery which damages these endothelial cell will lead to corneal blindness, जिसको हम aphakic, pseudophakic, bullous keratopathy or Fuchs dystrophy, all these pathologies will damage these endothelial cells. Now, why we should know very clearly about the layers of the cornea? Because now we are doing lamellar keratoplasty. So I'll just briefly tell you about the lamellar transplants which we are doing. So these are the 6 layers of the cornea. These are the normal layer: epithelium, Bowman's membrane, stroma, then Duas layer, then this is the Descemet's membrane, and endothelium. Now, when we are using the whole cornea, cutting the whole cornea, and transplanting. This is known as penetrating keratoplasty. So you can see we'll cut the whole cornea from the epithelium to the endothelium, and the whole cornea will be transplanted to the recipient. This is penetrating keratoplasty. Now, in some condition, which I was telling, where there is only corneal opacity in the anterior layers of the cornea, that is the part of stroma. So here what we can do is, we can just remove the epithelium, Bowman's, and part of these like lower layers of the stroma, and we can replace this by the donor tissue. This is known as deep anterior lamellar keratoplasty, or DALK, which you all must be knowing. Right? So if anterior tissue is damaged, we'll do DALK. Now, then the next layer, if suppose the endothelium is damaged. Now, in these endothelium, what we will do is, we'll remove, suppose the endothelium is damaged, we will remove this endothelium from the recipient eye, and we can do a retrieval in two ways. One is Descemet's, only we can remove the Descemet's membrane and the endothelium, which is used in DMEC. I'll explain later. And in DSEC, that is where you are cutting the corneal tissue by automated machines in the eye bank. Then the part of stroma also comes. So from this part of the stroma from the donor, and then a part of stroma, Descemet's, and endothelium. All the three layers will be there in DSEC tissue, right? So I think most of you must have seen these equipments or instruments and must be doing retrievals. So this is our anterior chamber. We mount the cornea on this anterior chamber and just cut the anterior part. This is the stroma and the epithelium. We remove this part, and the remaining stroma, Descemet's, and endothelium is the DSEC tissue, which we then distribute to the corneal surgeons. And this is the Descemet's membrane and the endothelium, which we will peel and then finally load in the cartridges, or sometimes we can do it directly in the OT. So if you see this DMEC tissue here, we are just transplanting the Descemet's membrane in the recipient. In the DSEC tissue, we are transplanting part of stroma, Descemet's, and endothelium. So I think this part is also clear. I hope it is clear to everybody that, and one important thing is that if we cut this tissue, if we are cutting, suppose this tissue, this is the donor tissue, we cut part of the stroma, anterior part, and we can use this tissue for DALK, and the lower tissue, if it is healthy, we can use it for DSEC or DMEC. So one cornea can be used for at least 2 transplant if it is healthy tissue and you have 2 recipients together. Right, then the next layer after the cornea is the sclera. So sclera is the white part of the eyeball, right? The white and the posterior 5/6 part of the outer coat of the eyeball. And this is totally white because here the arrangement of the collagen is different, and which causes this to become opaque. And this is a very important function of the sclera. First of all, protection of the intraocular contents. And the second thing is that this sclera acts like a black box. You all must have seen a camera, right? So this is the aperture of the camera, and the rest of the camera is all opaque. Because if the light will enter, and suppose everything is transparent, then a proper image will not be formed on the screen. So this screen is like our retina. This pinhole aperture is like our pupil. And in camera doesn't have that, but it has a lens in front. So our cornea and the lens itself, they act like a lens of the camera, right? Then the next part we'll talk about is the uveal tissue. The second layer which I talked about, the second vascular pigmented layer is the uveal tissue, which is divided into iris in front, then in middle is the ciliary body, and behind is the choroid, right? So we divide this into these 3 parts. So iris again gives the color to the eye. So when we see a blue colored eye or a brown colored eye or a black colored eye, this is the color of the iris, and it is not the color of the cornea because cornea is transparent, right? So this iris has few muscles inside this, and which helps in, now iris in the center is deficient. So this is the pupil and this is the iris. So these muscle helps in contracting the iris or dilating the iris. Pupil, sorry, contracting the pupil and dilating. So why it is important? Suppose we are in the dark. Suppose हम लोग जैसे dark light में जाते हैं तो अंधेरा हो जाता है वहां पे. So the light entering the eye is less. So what happens? This iris will contract the muscles and there will be dilatation of the pupil. ठीक है, तो pupil का aperture बड़ा हो जाएगा तो light अंदर ज्यादा जाएगी and we can see the image clearly. Now suppose you go in a bright light like in sun, so there is a lot of light. So if you must have seen, suppose when we dilate the pupil and go in the eye, light, we cannot open the eye. So a lot of light is going inside the eye. So here what we do is, what the body does is that they contract, they help some other muscles, they contract, and then this causes the pupil to constrict. So the iris will constrict and regulate the amount of light going inside the eye. It gives to the color to the eye and it regulates the aperture of the pupil. So these are two things. Then second is the ciliary body. Now this ciliary body is again very important. Now first of all, I just told you that there is an anterior chamber which is a clear space between the cornea and the iris, and this has a fluid inside it which is known as aqueous humor. So this fluid is secreted by the ciliary body, and this fluid maintains the intraocular pressure of the eye. So you must have seen while doing corneoscleral retrieval, if you puncture the anterior chamber, the cornea sinks down because aqueous goes out and eye becomes very soft. So it is because the aqueous has drained outside. So this ciliary body or the aqueous maintains the intraocular pressure. And the second thing is there are certain ligaments which are known as, like, they are threads which holds the lens together. Now this ciliary body also has some muscles. Now this muscle will help in changing the shape of the lens. So what happens is when we are seeing something like in a distance, so lens ka aperture change ho jata hai. When we see something,
Arindam, please mute your.
Yes.
So when we see something at a distance, so what we see them clearly. When we see them some near thing, then also we see it clearly. It is because our lens is changing its shape, right? So when we grow old, like after 40, these muscles get weakened, and this action of change of lens will not be there. So we become presbyopic and we start using glasses for near. So this is the process, and also cataract also start developing. So this also leads to the lens does not change its aperture. Then the last layer, the pigmented layer, is the choroid. So now this choroid is again pigmented and vascular, and this helps. The important function of choroid is to give vascular supply or nutrition to the retina, which is the most important layer of the eyeball. Right? So now we'll talk something about these lens. So like we see this lens, when I tell my patients, I tell them that cornea and lens opacity, that is cataract. So once the cataract develops, this lens become opaque. So the light will not be able to go inside the eye, and it will become, the patient will become blind. So the most common cause of blindness in India is cataract. The second most common cause, now we all know, that is the corneal opacity. So I tell my patient that cornea and lens are like bulbs, and the retina and the optic nerve are like the wire of that bulb. So if suppose something happens to the bulb, suppose cornea is damaged or suppose lens is damaged, we can replace them, and there can again light can go inside the eye. But if this wire or the optic nerve or the retina is damaged, then if we change the bulb, it will not get lighted. So अगर lens change करेंगे, cornea बदलेंगे, लेकिन optic nerve damaged है, तो patient को vision नहीं आएगा. So this is a very simple way to tell them कि bulb को change करेंगे, bulb खराब हो गया, तो तार ठीक है, तो bulb जल जाएगा. You can be able to light the bulb. But if your wire is damaged, then you cannot give light to a person by just changing the bulb. Understand? Right. So now we as counselors and technicians have to see these three things. One is the fake lens status. So phakic status, suppose the lens is there, this is phakia. If the lens is not there, then the pupil appears jet black and it is known as aphakia. Aphakia means there is no lens. Phakia means there is lens. So this is a clear lens, right? The pupil, when you put a torch on the eye, the reflex will be like grayish black or jet black in case of aphakia. Now, once your lens become cataractus, it will become brown or white. So when you put your torch here, you will see some brownish reflex from the pupil. So this is your cataractus lens. And the third thing is the pseudophakia. When you replace this cataract by a artificial intraocular lens. So this is pseudophakia. So when you see, just put your torch over the eye, you'll see a glassy reflex over the pupil. जैसे टॉर्च को ग्लास पे शाइन करेंगे तो वैसा जो रिफ्लेक्स आता है वो दिखाई देगा. So we all need to get train ourselves to see on torch light. And when you are doing the retrieval, I think you all are being trained to see the lens by scooping the lens out, whether it is pseudophakia, cataract, or phakic status. Sometimes these patients have an anterior chamber lens, so it is over the iris. So this lens can be found over the iris. This lens is behind the iris. Now coming to the next very important layer, that is the retina. So when we cut, this is the cut section of the eye, and here all the layers, the outer sclera and the choroid is removed, and from there you can see the retina behind. So the blue part which you can see here is the retina. And this retina is the most important layer of our eyeball because they have got cells which will deliver the light which is focused or the image focused on the retina via this optic nerve to the brain. And our brain will then interpret the image. So if suppose this retina gets damaged, then we cannot like help the person. We cannot help them just by a corneal transplant. Right now, the next structure, the last and very important, again, this structure is the optic nerve. Now, this optic nerve is attached to the eyeball, and you can see the optic nerve head here. So we all can see the optic nerve head in the eye when we see when we do the retina examination. So from here, it goes behind the eye, then it enters the bony structures, and then it goes into the brain. Now, from the brain, it will go to the cortex, the occipital lobe, and there they will interpret the image. So lens and cornea will focus the light at the retina. Retina se transmit hoga through the optic nerve, and then it will go into the brain. So this is the most important structure. If this optic nerve is again damaged because of many reasons, because of tumors and many pathologies, optic nerve tumors, brain tumors and all, this can be damaged, and then we cannot give vision to the patient. So this was all about the ocular anatomy. Once again, I'll just show you, you should have just a visual of this eye and orbit. I'll just show you. So this is the skin. So this is the skin, and you can see the lids. When we remove the skin, then comes the fat, and this is the fat. When we remove the fat, then this is the eyeball with the extraocular muscles. Right? इसमें वो एक structure को they'll remove and they'll show you the internal structures. This is the sclera. This is the cornea. So this is the lateral rectus muscle. This muscle will help the eye move towards the ear outside. This is the superior rectus muscle. This helps in moving the eyeball upwards. So this is the superior oblique. Now, there are muscles which can move the eye up and can rotate the eye also. So this will help in rotation of the eyeball. So this is the medial rectus, will move the eye medially towards the nose. And when we are doing the enucleation, we have to cut all these muscles to free the eyeball from these muscles. So this is the lateral rectus. Now, this is the inferior rectus muscle, which helps in moving the eye down. So you can see all these muscles will join in a form of cone. This is the oblique muscle. This again helps in rotating the eyeball. And now behind the eyeball, you can see this is the optic nerve. So from the retina, the image will go through this nerve and will go into the to the brain. Now we will start removing the structures of the eyeball, and you will see the structures below this eyeball. So first we'll remove the cornea, फिर उसके नीचे आता है iris and the anterior chamber. So this is the anterior chamber. Then we remove the sclera, तो ये हो गया ciliary body, and then this is the choroid, green color, and in between is the pupil. The pupil, iris, ciliary body, and choroid, which is the pigmented vascular layer of the eyeball. Now, when you remove the choroid, iris, so you see this is the center is the lens, ciliary body, and this is the retina, the yellow part. So this is the retina. Then just behind the lens is the posterior chamber, and now when we remove the retina, this is the vitreous, and this is the lens. Just to give you an overview, what all we have discussed. So when we remove the vitreous also, you will see the muscles, how they are arranged in the orbit. That's it. So this is the clear lens, and this is the muscles, and this is the optic nerve. So when we remove the whole eyeball, we have to cut optic nerve, all the extraocular muscles to remove this. I think this is all. Any questions? There are a few questions which I want to ask you. I think, should I continue or any questions now?
Ma'am, you should continue. We can take the questions at the end.
So my first question is that which structures of the eye we need to cut to do the enucleation or whole eyeball retrieval. So कौन से structures eye के हमें काटना होगा जब हम लोग पूरा eyeball retrieve करेंगे. Anyone can unmute and answer.
Optic nerves and all muscles.
Pardon? आपकी आवाज.
All muscles and optic nerve.
हाँ, so बहुत अच्छा आंसर दिया आपने. मसल्स, ऑप्टिक नर्व, लेकिन उसके साथ में आगे हमें कंजंक्टिवा भी हटाना होगा. कंजंक्टिवा, टेनॉन्स, उसको हटाना है. फिर मसल्स को काटना है, फिर ऑप्टिक नर्व को काटना है, फिर आईबॉल बाहर आ जाएगा. Very. So we will all these structures. Now, second question is, what structure we cut in corneoscleral rim excision or retrieval? तो corneoscleral button जो हम लेते हैं, उसमें कौन से आई बॉल के स्ट्रक्चर्स हमको काटना होता है और किसको हमें प्रिजर्व रखना होता है.
Only we remove the conjunctiva and 2 mm and 4 mm scleral rim in 360 degree.
नहीं, कंजंक्टिवा भी काट, मतलब हम उसको लेते हैं क्या कॉर्नियोस्क्लेरल?
नहीं, we not.
कौन से स्ट्रक्चर्स को हम काटेंगे जब हम कॉर्नियोस्क्लेरल रिम निकालेंगे? मतलब कंजंक्टिवा तो रिमूव करके सेपरेट कर दिया, उसके बाद
सेपरेट कर दिया, उसके बाद 2 mm और 4 mm को स्क्लेरा हम लेंगे. और
कॉर्निया नहीं लेंगे?
कॉर्निया तो साथ में आएगा ना.
हाँ जी. तो कॉर्निया एंड स्क्लेरा.
corneal rim.
Yes. So now somebody else can answer. How many corneal blind can be benefited from one eye donation? If somebody else can answer this question.
Madam,
10.
Yes.
मैंने आपके एम्स में ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंस में देखा कि 5% बेनिफिट टू वन आई. दैट्स व्हाई 10 पीपल्स आर बेनिफिटेड.
नहीं, दोबारा आप एक बार बताएंगे
मैम.
हेलो, like 1%.
Can you hear me? 1%. Hello. How many corneal blind can be benefit from one?
Ma'am, can I?
Yeah, you can. Ankita, you are Ankita?
Yes, ma'am. My name is Ankita. Ma'am, there will be 2 people will be beneficial if one corneal, 2 corneal blind people can be removed from this one corneal donation.
So if there is an eye donation, so we will get how many corneas?
2 corneas, and from one we have a 2 blind person can be like operated over there. That means total 4.
Total 4. We cannot say that there can be 6 there are a lot of like misinformation, but एक कॉर्निया से एक टाइम पे 2 टिश्यूज रिट्रीव कर सकते हैं, 2 लोगों को लगा सकते हैं, दूसरे आई से 2 को, तो टोटल 4. So 2 people can undergo DAL and 2 people can undergo DSEC together. और अगर
Exactly,
PKP कर रहे जैसे ये penetrating keratoplasty, then only 2 people can get corneas. अगर full thickness कर,
Yes, ma'am.
एक कॉर्निया एक को लगेगा, उसका दूसरा कॉर्निया दूसरे को लगेगा.
Sure.
So minimum 2 and maximum 4.
Thank you, ma'am.
अच्छा, ये तो मेरा आंसर पहले आ गया. कॉर्निया ऑफ अ पर्सन. हाँ, तो अगर किसी को रिफ्रैक्टिव सर्जरी हुआ है, मतलब किसी का लेसिक सर्जरी हुआ है या किसी का ये PRK हुआ है, कोई जो चश्मा हटाने वाली सर्जरीज होती हैं, तो क्या वो कॉर्नियल ट्रांसप्लांट के लिए हम यूज कर सकते हैं?
Cornea of a person.
मतलब आंसर इज ऑलरेडी देयर.
Answer is no. কি বলছে cornea of a person who has underwent a refractive surgery, কোনো রকম সার্জারি হয়েছে বা কর্নিয়া ট্রান্সপ্লান্ট হয়েছে, সে কি যোগদান করতে পারবে? হ্যাঁ, না পারবে না। Already
The answer is no, we cannot use the cornea because उनके कॉर्निया में ऑलरेडी हमने ऑपरेशंस किए होते हैं, and these corneas are very thin, मतलब thinner in size and will not benefit the person जिसको हम ट्रांसप्लांट करेंगे. So when we are going for a corneal retrieval now, we should always take this history from the families. Has the patient undergone any corneal refractive surgeries? चश्मा हटाने वाला कोई ऑपरेशन हुआ है कि नहीं हुआ है, पूछना चाहिए. एंड व्हेन वी आर डूइंग द रिट्रीवल, अगर कोई भी हमारे पास इंस्ट्रूमेंट है जिसमें कोई रिंग होता है, अगर हम उस रिंग को लगा के देख सकते हैं, अगर ओवल बन रहा है तो वी नो दैट दिस कॉर्निया इज नॉट गुड फॉर ट्रांसप्लांट. बाकी हम अपने कॉर्निया रिट्रीव जब हम इवैल्यूएट करते हैं, वी कैन डू इट, बट केराटोकोनस और कॉर्नियल रिफ्रैक्टिव सर्जरीज ऐसे नहीं पता चलेगा जब हम रिट्रीवल के लिए जा रहे हैं. सो कोई भी आप रिंग को अगर कॉर्निया पे लगाए, कोई भी रिंग की इमेज देखेंगे, अगर वो सर्कल बन रही है, इसका मतलब वो कॉर्निया फिर भी ठीक है. अगर ओवल है तो वो कॉर्निया बहुत अच्छा नहीं होगा शायद. Now, can retinal blind donate the eye? This is my next question.
Can retinal blind donate eye? Yes.
yes.
So I think
Yes,
this
ma'am.
is clear. So retinal blind, अगर उनका तार खराब है, but cornea bulb ठीक है, cornea is okay, so they can donate the eyes. And can a corneal transplant recipient donate the eye? मतलब जिसको corneal transplant हो चुका है, क्या वो अपनी eye donate कर सकता है?
Yes, ma'am.
Ideally
In
मतलब
art,
कर
no,
सकता
no,
है,
ma'am. Actually,
कर सकता
कर
है
सकता है,
मैम.
मैम.
कर सकता है, लेकिन उसको
क्योंकि वो last
transplant के लिए यूज करेंगे कि नहीं करेंगे?
Exactly, ma'am.
So
Exactly.
we will not use it for corneal transplant.
ट्रांसप्लांट
Want to donate?
और थेरेपेटिक पर्पस.
So this is all. Thank you so much for your patient hearing. Thanks.
थैंक यू मैम.
Thank you, ma'am.
I'll be happy to answer.
Please send your
थैंक
questions
यू.
in chat. Or you can unmute yourself and ask the question.
Good evening, madam. Hello.
Yes.
Madam, can the whole eyeball transplant right now? Any thesis proposal is there? If possible?
As per my knowledge, until now, I don't think the whole eyeball is being transplanted.
Yes, madam. Yes, madam. Thank you. Some fake articles I have seen. That's why I'm making confirmation, madam. Very good answer. Thank you. Thank you for your valuable suggestion.
Dr. Neeti, can't we use
Can you tell something about the article?
Can we?
Dr. Neeti, can't we use this refractive surgery done corneas for EK surgeries?
Yeah.
Yeah, we can use it
I wanted to. Yes, Neeti, go ahead. Neeti, go ahead.
Yeah, so in I just forgot to mention this thing. If suppose the endothelial count is good in these cases, you can use it for EK, but you cannot use it for the whole corneal transplant, PKP, penetrating keratoplasty. You can use it for endothelial keratoplasty.
Right. Thanks.
Yeah.
Yeah, बहुत लोग को like those who go laser means for lay person it is so many lasers. So I think it's not an absolute contraindication because laser, retinal laser also they think it is a laser. I think
Right.
better to collect, and PRK definitely can be used for endothelial keratoplasty. LASIK is a little bit difficult, but I think if we tell them, they might think that retinal laser is done, so there is a contraindication.
Yeah. And ma'am, second thing is, there's one question, like if suppose there is a keratoconus, so then also, like suppose there is a Descemet's tear and these counselors will not be able to understand. So should we take their corneas or not? Like sometimes we get these calls.
Yeah, early keratoconus, even if we bring also, will not be able to know. There are some studies where OCT they do and know, but it is challenging. But Descemet's tear you can bring because you don't know. Once you know slit lamp examination, definitely you will know.
We'll reject it. Yeah.
But the early keratoconus is definitely it's difficult to know. We don't know whether it is keratoconus or not. Unless absolute, like unless the pachymetry is very thin.
Hmm.
Can I ask you one question?
Yeah, yeah.
Madam, as far as cornea tissue is concerned, minimum 2, maximum 4 corneal transplant that can be done.
Yeah.
Even from the sclera, you see, other than in situ, when you take the whole globe, even the sclera you are going to make use of it, correct? From each sclera, from eyeball, how many sclera patch graft can be made use of from each one?
So, like usually what we are doing is we are cutting the sclera into 4 petals, but sometimes in our eye bank we are using it in glycerine also. So you can use it according to, suppose the whole sclera can be used for what you call it, eyeball implantation, like the orbital implants. So when we can wrap the whole sclera in an orbital implant, so it will use it in only one surgery. But for small scleral patch graft, you can use it in multiple surgeries. The only thing is you have to maintain the sterility of the sclera.
Okay, so from each sclera, even multiple patch grafts can be done, is it?
But we cannot say that one eye can give us 6 or 10 transplant. We cannot say that. Transplant usually is of the cornea. Scleral transplant is for the protection of the eyeball.
Yeah, it's like only a patch graft. That's all.
Yeah, it's a patch graft.
Thank you.
Yeah, patch graft, and then glaucoma people use many times for the AGV. So depend on what size you're using.
Hello.
Yeah,
Yeah.
please go ahead with the question, and you can also type it in the chat box as well. Any questions from anyone? Dr. Sujata, shall we move forward then? We already
Yes,
are
yes,
on
right.
time.
Yes.
I'll request Mr. G. Ganesh, Executive Director, iBank Association of India, for his address. Ganesh?
It's been a very good participation from many of these technicians who come here to attend this excellent presentation from Dr. Neeti, Gupta. It was really very good explanation. I mean, a layman can easily understand, and technicians who have undergone such experiences in their working, I think they have got very good.
Thank you, Ganesh.
Doing the whole thing. I think it's a very good thing. And as Raki was telling and ma'am was telling, it's a series of 8 webinars planned for the entire technician for making sure that technician certification is completed in all ways, because many things are overlooked. Very simple things are overlooked as you get experienced and as you get more and more work being done. So it's very important that the step-by-step process is followed, for which we need to definitely undergo this kind of a certification process and renew it every time whenever possible, so that things go on smoothly. So that's the reason why this webinar series is planned. because in the last Varanasi meeting, when we had done the first certification program, we found that even experienced technicians were found wanting in some of the basic procedures. I mean, it's not a critical thing, but it need not be continued further. So for that, we need to make sure that all these things are followed pretty meticulously. And I think we should make this, like ma'am was saying, that we should make it as a practice so that all the technicians are up to mark for the global level of practices in banking. Because as we move forward, it's not a short time when we'll be supplying corneas outside India also. So let's make sure that we reach that goal. And as you're seeing the screen, we have this 14th National Conference in Bhubaneswar. So please, all of you, block these dates and make sure you're all there. We'll have a lot of things going on at the conference. So hope to see you all there.
Rakshi, can you please announce the next date for the webinar so that people know?
So we will be having the next webinar again on the next Saturday at 3 o'clock the same time. I will be sending the details to everyone who have registered separately on the emails. If everyone can also scan this, we will be sharing all the information here on the EBAI webinar group so that they remain updated here. They can also send your questions here as well in the group. So request everyone to get themselves registered. Everyone who will be attending all the 8 webinars will be getting a e-certificate from EBAI for the attendance. So I request everyone to continue with the webinars in the future as well. I would also would like to thank IPCA for the support they have provided for this webinar. Thank you so much. Over to you.
There is a question.
Yes.
There is a question in the chat box.
Oh. Can a patient who has keratoconus can donate eyes?
Yes, so that's what we told. We don't like very early keratoconus, it is difficult to die. But if it is advanced keratoconus, definitely it cannot be used for optical purpose. But when you retrieve, it is difficult to know. Even unless it's very advanced, you do slit lamp examination also, you will not able to know. Unless there is a scar. But the tectonic purpose, yes. Research, yes. But optical purpose, advanced keratoconus cannot be used.
Hope that answers the query. One more request to everyone, if they have not put their name in the attendance, in the chat box for the attendance, please do the same. Now, Ganesh, can you also talk about a little bit about the certification which we are going to have at the Bhubaneswar conference, so that everyone is aware?
Like we did in Varanasi, we are going to do this certification program again. As you are all aware, a technician is now allowed to enucleate. And a certified technician is one who is certified as being proficient in eye retrieval by an eye bank, which is registered under the Human Organ Transplantation Act. So this is a basic requirement for technician, and for that to happen, the certificate is necessary. So it's important that if somebody questions you next time, whenever you go for retrieval, you make sure that you have this certificate with you, so that people cannot create any problem while you are retrieving, saying that no, only doctor should do, or things like that. So this certification program is also important, that it kind of helps you keep up with the latest practices in eye banking, so that ultimately the recipient is the focus for us. So let's make sure that we take care of the requirement of the recipient by following the proper standard procedures for technicians' activities. So this, as usual, we have this certification program. The technician will have to go through the entire process, and then they'll be graded according to their this thing, and they'll be given a certificate end of the session. So make sure that whoever has not got certified, to get certified. Of course, it depends on the number of technician evaluation slots available there. So be the first to register yourself so that all the technicians who are registered can be certified at the Bhubaneswar conference. Thanks.
Thank you. Thank you, Ganesh. Sujata ma'am, if you permit, we can close the webinar.
Sure.
मैम मेरा एक क्वेश्चन था, अगर आप
Please, yes. Please go ahead with the question.
हेलो
Yes, please go ahead with the question.
हेलो
जी सर बोलिए.
मैम ऐसा है, मैंने ग्रीफ काउंसलर से स्टार्ट किया था अपना ये कैरियर इस सेवा के अंदर.
जी सर.
और मैंने लगभग 10,000 डिसीज्ड पर्संस की आईज ले चुका हूं मैं ऑलरेडी
जी.
लेकिन ये था कि अब बीच में एक परेशानी आ गई जिसकी वजह से अब हमने स्टॉप किया. एक आई रिकवरी टेक्नीशियन ही ले सकता है. बेसिकली आई एम एमफिल एमकॉम बीएड. आई एम हैविंग द लॉट ऑफ एक्सपीरियंस इन आई डोनेशन.
राजकुमार जी, हम इस क्वेश्चन को ऑफलाइन ले सकते हैं.
जी ठीक है मैम.
इस टॉपिक अभी हम इस टॉपिक पे, अगर ऑक्यूलर एनाटॉमी पे किसी को कोई सवाल है तो हम उस पे बात कर सकते हैं.
मैम सॉरी मैम, सॉरी.
नो वरीज.
थैंक यू मैम.
Shall we close the session now?
Thank you all.
जी.
Thank you जी all.
Thank you so much. We have our webinar group for everyone to join. If you have questions, you can share the questions there. Dr. Neeti will be happy to answer the questions there as well. Thank you so much. Thank you, Dr. Neeti, for taking out time and having this wonderful session. Thanks to Ganesh, Dr. Sweta ma'am.
Thank you, Neeti.
And last but not the least, all the participants for coming, attending the session so actively. Looking forward to see you all again in the next session. Thank you so much.
Thank you, Rakhi.
Thanks a lot. Thank you.
Thank you, Rakhi.
Thank you very much.
Thank you.
Thank you, Ganesh.
Thank you, sir.